Welcome to the Hazard Class Podcast. This is the podcast where I ask my stupid questions to some of the smartest people in and around the world of emergency response. In our last episode, we had the opportunity to speak with Kevin Hazard about his book, No One's Coming, which chronicles the extraordinary efforts of a small group of people who stepped forward during the 2014 Ebola outbreak. This week, we're taking that conversation one step further. Instead of talking to the author who told the story, we're talking to one of the people who actually lived it. Our guest today is a board-certified emergency physician and the medical director for Phoenix Air. During the Ebola outbreak, Phoenix Air became the organization trusted to perform some of the world's first long-distance airborne biocontainment medical evacuations, transporting critically ill Ebola patients from West Africa to advanced treatment centers inside the United States. He was part of a team that developed, refined, and executed these groundbreaking missions, helping prove that patients with highly infectious diseases could be safely transported while protecting flight crews, medical personnel, and the public. His work required a unique combination of emergency medicine, aviation medicine, infectious disease response, and operational risk management under intense public, domestic, and international scrutiny. It's my pleasure to welcome to the show, Dr. Doug Olson. Dr. Olson, thank you for joining me.
Hey, I'm glad to be here. Thank you.
Yeah, it's as we were kind of talking prior to the start of the show, I've read the book and I'm super interested, super fascinated by the whole process. Not only someone that works in emergency medicine like myself, but also someone that works in hazardous materials pretty extensively too. It's really the combination of the two of those things to make this mission and this operation successful, which is, honestly kind of beyond belief. And I can't wait to ask kind of the granular questions that maybe, I was left out in the book because it has to be written for the general public. But before we get to all the I don't know if fun is the right word, but interesting Ebola stuff, I want to get back to the roots of kind of your motivations to get into medicine in the first place. So, I generally try to start my shows off with this question, which is the why. Why medicine?
Yeah, I mean, my dad was a physician. Most of my family was blue collar, but my dad was actually a physician. And when I was a kid, I would go on hospital rounds with him. He worked in the hospital. He was family medicine, but he was kind of the original family medicine type docs that did a lot of different things, including a lot of OB. And used to love doing that. My parents didn't. They encouraged me to work hard and treat others well, and that's were those big things. But I wasn't forced to go into medicine. It was my decision, actually. But I think early on, that influence of seeing my dad and how he treated people played a big part in that. So my original goal was really always to go into medicine. I didn't plan on emergency medicine until I was in med school, but before that, I was actually planning on going in the military first. I wanted to do the military, not in medicine, actually. I either wanted to be a pilot or I wanted to do something in special operations. But my dad was a Vietnam vet, had done a couple of tours in the Marines in Vietnam, and unfortunately had a lot of Agent Orange exposure and had a lot of health consequences because of it. And so with my dad's illnesses and so forth, I decided not to go in the military because I needed to spend more time being close to him, since he was dealing with a lot of health issues and unfortunately died earlier in life because of them. So I changed my plan and went into medicine earlier than I had planned to do that.
Well, I'm sorry to hear about your dad. I had an uncle that also passed from Agent Orange exposure. Mm-hmm. It's just brutal.
It was.
What was the thing about emergency medicine in particular? It sounds like you maybe had kind of a proclivity to thrill seeking, or at least like the tip of the spear kind of, you want to be a pilot, you want to be in special forces, like that kind of person seems like there's an archetype. So, but what was it that drew you specifically to emergency medicine?
when I first started med school, my plan was to do cardiothoracic surgery actually. And so I rotated through my different rotations, and I loved surgery, to be honest with you, but I realized that was the only thing I could do if I did CT surgery, was just basically work in the office, in the operating room. And so I was one of those people that like to do a lot of different things. And I think, like you mentioned, that draw for special operations, aviation, I just liked doing a lot of different things. And I like the unpredictability of working in the emergency department, faster pace. I'm not a big fan of being on call, although I'm always on call now, oddly enough, from an administrative standpoint. But I think really it was just my my short attention span and my love of being involved in a lot of different things. And I saw early on emergency medicine was an avenue for me to be involved in a lot of different things, not just working in the hospital.
Mm-hmm. Where do you think that drive came from? Were you like I don't know, some sort of crazy thrill seeker in your youth, or you were like jumping off trees or cliff diving or some sort of thing like that? Or where does that come from?
Yeah, I think my parents both thought I was going to die doing stupid stuff when I was in even before high school, to be honest with you. I think my adrenaline rush was the need for adrenaline rush was there, but also I didn't really have much of a fear factor. So there's a little bit of that involved too. So I think, yeah, I mean, I think my dad was not surprised when I chose to do emergency medicine. He died, fairly soon after I went to emergency medicine, but he was not surprised by that. But I think, yeah, there was that, like you mentioned, there's that adrenaline rush, and then just I love doing the different stuff, and so that's translated throughout my life and my career, actually.
Mm-hmm. So how long are you in the emergency medicine world before you start kind of going outside the traditional box that is the ED?
It actually started when I was in med school, to be honest with you. It was kind of funny. My cousin and I were in medical school together. He's an anesthesiologist, actually, but we had a neighbor of ours who was a police officer in San Bernardino County. I went to med school in California. Pretty violent county in that area. And then actually one of our classmates, who was one of our best friends going through med school, had worked many years in law enforcement, actually, and then he decided to go into medicine. And so that was kind of the first introduction. I mean, I think I realized there was an opportunity to do tactical medicine type of stuff early on. So when I was in med school, that was my first interest, actually. So my cousin and I we would go on ride-alongs with the sheriff's office and also the police department. And our neighbor was on a full-time SWAT team, but he was also in a SMASH unit, was basically an anti-gang unit. So they were doing anti-gang primarily, and then when SWAT operations happened, SWAT would happen. And so we had a lot of conversations. I went on a lot of ride-alongs with him, and I think that was my first, like, hey, I think there's a chance that I could do something outside of the hospital emergency medicine that would translate with law enforcement as well, and be there to support them. And so that's when it first started. So when I applied to medical school, to residency, I interviewed. It was a very competitive program at that time to get into. And so I interviewed actually in Georgia. Never thought I'd move to Georgia, to be honest with you, but the residency director at that time, I didn't know anything about him. He was a former 5th Group. He was a former Green Beret, had deployed to the Middle East. And so he had a lot of experience. He had just retired from the military and went to the civilian world, but he was our residency director. So he asked me on an interview, he's in my residency interview, he's like, do you want to do anything besides just work in the hospital? Do you have any other interests? And I said, well, I'd really like to do tactical medicine. And he's like, we need to talk some more. So to make a long story short, I ended up matching at that program. And then he and I started the operational medicine and tactical medicine program at that hospital where I did my residency, and it's still in existence. After this many years, I'm getting to be old now. So, but it's still a thing. So we started training with local law enforcement when we went through SWAT school. Didn't let them know we were physicians. We didn't want them to know. We didn't want to be treated differently. And then it just kind of one thing led to the next, and next, and next. But that was the initial introduction when I officially started supporting law enforcement.
So when you think about that role inside of that sphere, inside of the tactical sphere, inside of the police, like how does your practice change? Is it just basically a scope of practice? You're much more trauma focused. But like, how do you, from the vast gamut, which is the ED, which is like literally anything can walk through the door, to now, like we're going to chop out, I don't know, 85% of that and be here. Mm-hmm. How does that hyper focus change the way you respond and act?
Yeah, so we had multiple roles really with law enforcement. So obviously we're there if there was a SWAT call out, we're there to take care of any trauma. So, our scope of practice obviously was part of that. So we were there, we weren't there to fully run a resuscitation and stop in the field. We were there to be essentially pre-hospital physicians until we could get the patients and whoever was injured to the hospital. But it also translated into, mental health related stuff with patients, SWAT call outs for people with mental health related issues. And that's why they were actually barricaded in the house. And then, so a lot of the time we would be consulted to say, hey, what do you think? Is this a person that you think is going to come out? Are they a danger to the other people? A lot of questions from the psychiatric standpoint from the SWAT commanders to make a decision whether or not we're going to make an entry or we're going to wait it out and what the risks were. Also just sick call stuff, to be honest with you. I mean, keeping the deputies or the law enforcement personnel healthy, I guess is the best way. We're not there to be their primary physicians, but if they had a medical issue or something on an operation and we knew their medical history, for example, if they were diabetic, and they weren't quite acting right, hey, is your blood sugar okay? That kind of stuff. So we're there for that kind of general sick call stuff as well. Any orthopedic injuries, and then we can, have a quick route of referral to the hospital and the specialists that deal with that kind of, the orthopedics, for example. Mm-hmm. So I think it was a broad scope of an involvement. It wasn't just for call outs like, hey, somebody just got shot, they need a chest tube, they need a rapid evacuation to the hospital. But we also, worked with a lot of the aeromedical or the helicopter evac systems. Just if we had a call out, we would provide GPS positions for a good LZ. So we were there for pre-planning as well to try to say, okay, we've got a medical plan in place. So that if there's an injury or something bad happens, we've got a rapid response so we can get to the hospital as soon as possible. And then in quotes, that golden hour, if you will.
Yeah. So that begs the next question, which is eventually, obviously you come on board with Phoenix Air. What came first, like the chicken or the egg? Were you working in flight medicine, or did you look at this opportunity with Phoenix Air and then adapt to it?
That actually came later. I started working with the federal government to do law enforcement as well. So I worked at the FBI, DEA, multiple federal agencies, and I deployed internationally with them, including to the Middle East. Oh, wow. So we started with local law enforcement and then ultimately ended up with federal agencies as well and worked with the military. And so we had a broad spectrum of groups that we would work with. Most of my medicine from the aviation experience was actually in a helicopter. But when I started doing federal agencies, then there was fixed wing aviation involved as well. When I decided to leave, I did my residency at the Medical College of Georgia in Augusta, Georgia. And so when I decided to leave, I stayed on faculty there after I was finished. And when I decided to step away from the academic world and go into the private world, honestly, I can't exactly remember how it happened. I think there was a flight nurse that worked with Phoenix Air Group who we encountered each other a few times at the hospital, and they said, you may want to consider working with this company. And I said, yeah, you can give my information if you want. And I got contacted by their medical director, Dr. Mike Flickiger. and I started flying with them. And pretty early on from when I left and I came to the Atlanta area. So it just kind of fell into my lap, to be honest with you. It wasn't something I sought out. And honestly, at that time, I didn't even know who Phoenix Air was.
Yeah.
So until I started learning more about them, and then I was like, okay, yeah, I enjoy working with these folks. So
Phoenix Air has become like this, I want to know everything I could possibly know about Phoenix Air. I'm so fascinated with like all the, like they outlined just some of the work they did inside of the book. And it's just like, oh my God, the scope of, from starting out with explosives to now, like, being a target for the Sea Whiz to like, what on earth is going on? Insanity.
Yeah, I mean, we're a multifaceted company. I mean, honestly, that's probably helped in maintaining its stability and existence, to be truthful. And so we don't just do air medical stuff. I mean, like you read in the book, there's a lot of different stuff we do. I mean, taking, the whales in the planes and dolphins and penguins and, to explosive materials. And, it's just kind of interesting. So,
yeah, if there's a weird thing that could be flown through the sky, Phoenix Air probably flies it, right?
Yeah.
So talk to me about how medicine changes at altitude. I know it does, but sure. To what degree and in what ways?
Yeah, I mean, so first off, depending on the transports you do, just from getting down to the nitty gritty of the type of transports we do, we sometimes have to change what altitude we're flying at, depending on what we're flying, and then who we can fly. Because of the altitude changes, you have to be careful about, the effects of altitude on the physiology of the patient. For example, some post-operative patients who've had, pneumocephaly, or they've had air in their brain, so to speak, would be susceptible to higher altitudes. A chest tube, we can manage them obviously in the aircraft, but we may have to adjust what altitude we fly at for those kind of situations. Patients with high elevated intracranial pressures, those are the kind of things that play a factor in flight physiology. We do a lot, actually. We can do a critical care patient in the plane. We've assisted with ECMO transports. In fact, we had one of the heaviest ECMO patients we've ever transported, and possibly even in the world. We did a few months ago, and fortunately the patient survived. We took them to Emory.
Wow.
But there's a lot of the physiology that goes into flight medicine. And the helicopter is not as big of a deal unless you're, Mount Everest or something like that. But here, when you're going to altitude, you have to think about, okay, what is there something about their illness or their injury that's going to make it such that we can't fly to the higher altitudes, and we have to pressurize and fly at a lower altitude so that we don't affect, have an issue with the transport of the patient.
Is that a thing that is kind of like pre-known? We have, whatever this condition, we fly from this altitude range, or is it like take them higher, see if they start decomping, and then we'll go lower, or whatever it might be?
Yeah, normally we know. Yeah, we typically make a decision. The reason why it's important is also for flight planning. So if we fly at lower altitude, and then that means that we have to refuel more likely, more times or earlier. So the fuel burn is higher at a lower altitude, so we're not as efficient. And so that plays a factor in. So a lot of the time we're fully reviewing the cases before we do a transport to make a decision, like, can we fly at a normal altitude that we normally fly, without a patient, or with a patient that doesn't have a flight physiology requirement. So usually we will know that beforehand. There have been a fair number of rare times, especially when you're going to remote places, that, and I think anybody pre-hospital understands this, like, you hear the story about what's going on, you get there and it's not exactly as it was built. And you're like, okay, this is not exactly what I was expecting. And so, I mean, anytime we fly with a full critical care package of equipment, so that we are, first off, if we get there and it's more than it was billed, then we're prepared for that. Secondly, like, if we have to get a diversion to somewhere else because that mission was canceled and we're going somewhere else, and we have a different type of patient that requires a higher level of care, then we're prepared for that at all times. So I think, in general, we'd like to be prepared as much as possible, but, as well as I do, it doesn't always work out that way in the pre-hospital setting.
Yeah.
So,
How does that work with the interface between the requirements of the flight from a technical standpoint, from a Phoenix Air standpoint, and then like local aircraft controls? Like, do they kind of understand the nature of the work you're doing and they give you special leniency to have more say in the process than other flights, or how does that work?
yeah, so if we're flying, typically, especially with a really sick patient, usually air traffic controls gives us priority in the air if we need it. Usually, we have pre-assigned flight routes, just like any other aircraft, even commercial aircraft, to our assigned destination. And then, of course, if we're traveling internationally, then you have to deal with overflight issues. And so, some countries they don't want you flying over their country. And so we may have to go around them to a destination. But in general, if we are with a critical care patient we're transporting, we assume a new designation in the air is called lifeguard. And so when we have that designation, air traffic control understands that we have a patient on board, and so we're more of a priority in as opposed to somebody else that doesn't have a critical care patient in the air.
Mm-hmm.
So a lot of our flight plans are already done before we even leave. But if we a lot of the time, once we have that lifeguard destination, air traffic may be nice to us and give us a more direct route.
Yeah.
And then the other thing too is if we have an issue, just like in a pre-hospital setting, if you're on your way to the hospital, and then then something changes and the patient becomes, has a deterioration, we may actually have to land earlier. Now, fortunately, that we are able to typically provide the care that we need in the aircraft. But if an unexpected sentinel event happens and we need to land earlier, then we let air traffic know, like, we need to land as soon as possible. And they give us vectors to an airport and then have an ambulance meet us there so that we can take the patient to the hospital.
So in understanding that you basically have a full ICU complement inside of this, aircraft, give me an example of something that could happen that is beyond the scope of what could be handled at altitude.
So, yeah, I would say if there is, typically, when we have a patient, they could be on a ventilator. We may be managing like a ventricular drain, or they may be on have a chest tube that we're managing as well. So that kind of stuff is routine for us to deal with. But if we have a sudden decompensation and we don't have a quick answer for that, and the patient becomes unstable, and we're addressing it, but the stability is not managed in the aircraft. So, for example, let's say if somebody has septic shock, and we've got them, they're on vasopressors, they're on the ventilator, and all of a sudden during route, we're troubleshooting because we realize they're becoming harder to ventilate and to maintain their oxygenation, or they become more and more, their blood pressure becomes more unstable during the flight, and we're addressing that with vasopressors, but they're still deteriorating. At that point, the decision is like, okay, do we need to go to the hospital? There's something more going on. We also carry an ultrasound. So if there's like a pneumothorax, we can handle that in the plane. But if you suddenly have that kind of a thing and you have a procedure that you have to do, for example, somebody's got developed a tension pneumothorax and you decompress them, then really you need to land sooner so that patient can be stabilized, get them down lower altitude, and then take them to a hospital so that pneumothorax can be managed and then stabilized before they can get an ultimate transfer to their destination. That's a pretty rare thing to happen, to be honest with you. Usually if we have an alteration of vital signs or something happens, we can stabilize it in the air. So it's very unusual for us to do a diversion. In the States, if we get to a patient and we get there and they are like way too sick to transport, and this has actually happened. So we get there and like it was not labeled as spilled. Now, mind you, we're an ICU in the sky, but we don't replace an ICU in the hospital. And when you've got an unstable patient, taking them out of the hospital is just enough sometimes to make them even more unstable and potentially, have a critical event happen in the aircraft.
Mm-hmm.
So if we get to the hospital and we're like, whoa, this patient is way sicker than we thought, they do not need to be in an airplane. They need to stay where they're at until they're stabilized and they can get to the hospital that their destination is. Then we may have to make that decision. Like, it's too risky to put them in the aircraft. So that doesn't happen very often either, but it's not a rarity. And so now, on the other hand, if they're in the middle of nowhere, Africa, and they're going to die in that hospital, their ability to care that patient is very limited. Then at that point, we have to decide, okay, are we going to say we're going to leave them there to die, or we're going to take the chance, get them in the airplane, knowing they're critical. There's a chance they could expire in the plane, but we're going to get them to tertiary care and give them a chance to live. And the answer is we're going to choose that we're going to give them a chance to live. And so, and those come up from time to time.
So this is going to maybe be a long-winded question, but so bear with me. I know so we were talking before this, and people that listen to the show know my wife's an ICU nurse, pediatric ICU nurse, and she takes great pride in the care that she can provide. Like she likes going to do the thing, which is like, oh man, this is crazy wild. There's 12 pumps going and all this stuff. What do you put in place to make these decisions black and white, if they are, so that these physicians, yourself included, or nurses or whoever might be working on these patients, aren't just going to try to muscle through the problem and try to solve it themselves, when maybe the better outcome would be to ask for help, which is maybe difficult for someone that wants to be able to will their way through it?
Yeah, that's a good question. I think first off, choosing our crews appropriately. We have some really amazing nurses and medics that work with us, very well experienced. A lot of ICU and ER experience. So we don't take anybody that comes just out of nursing school. They have to have experience before they come to us. And so I think there's a level of appreciation for the really sick patient, and like, there's the other part of them is the do no harm. And so I think all of them, if there's a real concern, let's say if I'm not with them, they will call me and say, I'm not comfortable with this, or what do you think? And we'll start talking through it. Typically, when we get patient transport decisions made, it's me and our other senior nursing leadership and medic leadership that make the decision, like, okay, are they fit to fly? Now, not speaking of those remote situations, and like in the middle of nowhere where you're just getting them out of there. So let's say if it's in the States. And so I look at every case, we go through their hospital stay, the physician notes, what their vital signs have looked like, how their labs have been trending, what kind of procedures they've had done. So we try to have a really good educated decision to say, yeah, they're fit to fly. We should be okay. Now, again, sometimes we get surprised and get there and something's happened that we didn't expect. But generally, our staff are really good at saying, we know our limits, and because we don't want to put our ego ahead of patient care and doing the right thing for them. And so I don't really encounter that, to be honest with you. I think everybody is really, really good about making a decision like, hey, we need to have a conversation about this before we take this patient out of the hospital. And then also, if they're critically ill, a lot of the time we'll have a physician with them as well. And so you've got that, the perfect team. You've got a physician, a flight nurse, and you got a flight medic who's also been cross-trained with a lot of ventilator training. And so you've got everybody works as a team to say, hey, is this the right thing to do? And so I think there's experience that do no harm, that, put your ego in check and say, okay, can we do this safely? And then also, like, is there stuff that we can do better to make the patient better? Frankly, and this is no, offense to any hospital out there anywhere in the world, even in the US, but sometimes we get a hold of a patient and they actually end up being more stable and doing better by the time we get them, because we've done our own management of that patient and route, and they end up being actually doing better than when we first picked them up. So
that's great. That's a great marker of success, I suppose. So that inevitably leads us to, you know, basically why we've got here, right? Or why we're talking in the first place, which is eventually you come on board and walk me through this, how we get here. But eventually you know, go from that kind of introduction, sending my information to Phoenix Air, to onboarding with Phoenix Air, to eventually, you know, the Ebola outbreak in East Africa, and them going like, hey, how do we bring these people home? Right. If anyone's listened to this, they probably listened to the episode with Kevin, which was previous to this, which we kind of break down what that story is. We don't need to get too granular and why you're doing this, but essentially there was an Ebola outbreak in East Africa. There was some medical aid workers there that contracted the virus. And now your team was tasked with the idea of bringing them back to the United States for a higher level of care. So bring me through not only how that happens, or like the beginning of that story, but what is that like as you go from, send them my information, to like now you're onboarded with Phoenix Air? Hey gang, how you enjoying the show? It's pretty cool, right? If you could do me a favor and just like and subscribe, it makes such a big difference. If you subscribe on YouTube and Spotify, Apple Podcasts, give the show a review. It makes a big difference to me. It's a small thing that you can do, and it makes a huge difference for the show. If you can do that, I'd really appreciate it. Thank you. This podcast is brought to you by Hikes Boots. You know, you can tell a lot about a brand by the way they choose to advertise. And Hikes didn't ask me to say anything specific. What they did was they sent me 2 pairs of structural fire boots. They sent me their Fire Eagle Air and the Fire Eagle Extreme. And they said, try them out, see what you think. And so far, they've been awesome. They're so comfortable. They fit kind of like an athletic shoe, very supportive. The Extreme is actually a lace-up boot, and it's crazy. I mean, I was skeptical at first. I'll give you that. I was skeptical, but man, it's just this one handle. You pull it up when you put on your turnouts, and it's so comfortable. But if you want to find out more information, check them out at hikesusa.com. That's HAIXUSA.com, or check the show notes for the direct link. Rigaku! Today's episode is brought to you by Rigaku Analytical Devices. And these are the folks that have been perfecting the 1064 nanometer ramen longer than some of us have even been doing hazmat. And they just launched their 4th generation handheld analyzer, the Icon X. And it's built specifically for real world things that teams encounter. We're talking about dirty powders, mixed materials, dyes, colors, and all the things that make other instruments throw a tantrum. This 1064 nanometer laser means reduced fluorescence. So that means fast, reliable chemical ID in under 1 minute. Instead of just staring at your blank screen, wondering what went wrong. And this isn't just, an upgrade. It is a whole new platform. It's a whole toolbox. It supports new accessories, standoff analysis. You don't have to get too close to get the answers you're looking for. If you want an analyzer that's been evolving right alongside the hazmat world, check out Rigaku's newest ramen at rigakuanalytical.com. Or check the show notes. Back to the show.
Yeah, so I started working with Phoenix Air years before. Actually, I was probably 8 years before the Ebola crisis in 14. So I'd done a lot of missions with them already. The medical director and I were good friends, and he was a very experienced physician, a good mentor, to be honest with you, with fixed wing aviation for me. And so we worked together a lot, and he started bouncing things off of me with my experience. And then also, I think he just trusted my instinct and my experience, and so we worked well together. And so when Ebola came about, it was already in the back of my mind. As soon as I knew, as soon as I heard there was an American with Ebola, I started wondering, okay, are we going to get a call about this? I knew our capabilities. We had never tested on Ebola. That had never been done, to my knowledge, I don't think, in any kind of from an aviation standpoint, especially in a long trip. Very dangerous. So oddly enough, Dr. Brantley gets Ebola. I'm at the outlets, and I'm looking for a cheap buy. And I get a call from Dr. Flickiger, our medical director, and he said, "Hey, are you available for an emergency meeting tomorrow?" And I said, "Let me guess, is this Ebola?" And he said, "Yeah, it's Ebola." And I said, "Yeah, I'll be there." And so technically at that time, I didn't have an official administrative role. I became the assistant or the associate medical director because it just got really busy. He asked me, can you be part of this meeting so we can make a decision on this together and for our crews as well. And so the next day we met with folks from State Department, CDC, multiple federal agencies, and the White House was involved in it as well, of course. And so we're sitting at a round table to discuss the disease itself. Can we do this? This tent, we call it the tent because it's easier to say, the Air Medical Biological System.
The ABCS,
yeah. ABCS, yeah. So we were discussing, okay, these patients are critically ill, highly infectious. It's extremely dangerous. It's already dangerous when you're out dealing with it in country, of course, but when you're dealing with a small enclosed space and doffing out of your equipment, that level of risk is infinitesimally higher because the amount of potential for exposure to that is very high.
So let me stop you for 1 second. I want to ask to climb inside your brain for a second when you get that call. Like, what's your knowledge base of Ebola? Are you like surface level? Oh yeah, it's this like bad virus, or do you understand the granular nature of Ebola at that point? Like, is it a strike of fear? Is it a strike of excitement? Is it a strike of uncertainty? What's going inside your brain?
Yeah, I mean, honestly, the first thing that popped in my head is, this is risky, for the crews, essentially. That was the first thing that popped in my head. I did know about Ebola. During training, one of my attendings was an expert in tropical diseases. So we had a lot of lectures. The hemorrhagic viruses were one of those that we talked about. Certainly I never thought I'd see that in U.S. soil, but working with Phoenix Air Group and knowing our background and potential for things that we could transport, certainly I probably knew more about tropical diseases than some people that worked out of the ER in the States. And so I knew what it was. The fine details of, how the virus attacks the immune system and so forth, probably weren't really in my bandwidth at that point, but I did know what the infection did. And I also very well knew what the mortality rates were that. Mm-hmm. And so I knew, like, okay, these patients get critically ill. And not only that, but they are highly infectious, highly risky, and the high mortality rate. And the idea that we had, in this meeting was, hey, we could get them a chance to live. They're in remote areas of Africa, limited resources for medicine, and they're doing the best they can. But with that being said, could Western medicine provide them something that they can't get there and increase their risk or their chance of survival? And the answer was, yeah, we felt like it was worth doing. And so I did know about it. We knew, obviously, before we went over, we're starting to get in the fine details of it too, just because, like, okay, what do we need to do to take care of these patients? And so because none of us had taken care of a hemorrhagic virus like that.
So for someone that might not know, can you give me like the 10,000 foot view of what Ebola is and how it spreads?
Yeah, sure. So the thought is that actually fruit bats are the carrier. They eat fruit and drop, maybe seeds or fruits, parts of the fruit that they didn't fully ingest, and then monkeys or primates then eat that. They get exposed to the virus. They're the carrier, and then humans. The thought is bushmeat, basically, because there they do eat a lot of bushmeat, and primates are one of them. And then the humans get involved, and so there is a zoonotic transmission, and to humans. So that's how it's felt to be transmitted. The problem with Ebola is it initially, and this is how an outbreak in the United States would be really, really, really complicated, is that it acts like any other virus. When they first start off, they've got a fever, they may have body aches, they may have a headache, then they start getting gastrointestinal symptoms. I mean, I see that every day I work in the hospital.
Mm-hmm.
So Ebola is not like at the top of my list of things to concern about unless I'm in an area where I'm like, okay, is this a tropical disease like a hemorrhagic virus or or hemorrhagic fever that I've got to consider. And so you've got that initial virus that starts. It's a 21-day incubation period, which also makes it complicated.
Mm-hmm.
And from a standpoint of contact tracing as well as risk of transmission. And so generally about 6 to 12 day mark is when they start developing symptoms. For that first few days, acting like any other virus, the virus invades, starts attacking the patient's immune system. I mean, it's a very complicated virus. It's a smart virus, and it starts attacking the immune system, puts you at risk for bacterial infections as well. Patients get GI symptoms and start getting a lot of electrolyte issues, a lot of fluid loss, and then ultimately it affects their liver and affects their kidneys. And so that's where the bleeding part comes, because it affects their clotting factors and so forth. And so patients literally can bleed from their eyes, get blood in their intestinal tract, bleeding from any IV sites, that kind of stuff. It's the ones who we refer to as the wet patients, meaning a lot of GI symptoms. Those are the ones with a high viral load that are really infectious at that time. If you get exposed to GI, like vomit and diarrhea, you're at a high risk of getting it at that point. So they just keep getting sicker and sicker and sicker, and that virus just keeps attacking the system. And then they also have a hard time keeping up with the volume loss that they're dealing with as well, and then maybe secondary infections, and then ultimately just can decompensate to a full sepsis picture, if you will, till they die.
Mm-hmm. And correct me if I'm wrong, but like, the viral load increases with symptomology. So like as they're asymptomatic, they're relatively non-transmissive. And then as they get more symptomatic, they become more transmissive.
Correct.
So that is one benefit to the process, right? Theoretically in these early, fever symptomology, when they may be walking around where they don't know what's going on, their viral load is relatively low. Still a problem, but not as problematic as they will eventually become.
Absolutely. And so that's completely right. I mean, if they're asymptomatic, the thought is that the data shows that they're not contagious at that point. But when they become symptomatic, then they are, but the risk is low in the beginning. The more sick they get, the more infectious they are. And actually, even after they die, and this is one of the issues in Africa, is that the families and the loved ones the way they deal with their loved ones' bodies afterwards, they prepare the bodies for burial, and that's what they're used to. And so they're still contagious. And so once they've died, that virus is still alive, actually. So when they're preparing, they are preparing their loved ones for burial, they're actually get exposed to the virus.
Wow. How long after, like post-mortem, is it still contagious? Do they know?
Days.
Yeah. And once again, correct me if I'm wrong, this is only transported through body fluids, right? It's not a thing like COVID or some of the other viruses we might be more familiar with that could be transported through aerosolized particle or something like that, right? It's going to be idea. Direct contact with fluids.
Yeah, direct contact fluids. And now it's really droplet. So, the tricky part is with the hemorrhagic fevers is that, for example, let's say if somebody's coughing, and normally respiratory-borne illnesses like COVID, for example, that's the way they get transmitted. That's not typically the way that Ebola is transmitted. But let's say if they're coughing and they've got blood in their mucus, and they cough in your face, and that blood gets into one of your, gets into your eyes, gets to your mouth. Like that's considered a droplet basically at that point. So that is a risk. And so when we do a transport of Ebola, I mean, every part of our body is fully covered with PPE, because you never know, like, could I get exposed not just I'm not worried so much about the airborne. It's the droplet stuff. And the patients can get really sick. And we actually had one of our medics have a patient just vomit. I mean, it covered him from his head to his toes. And I mean, I'm talking. And so, like, if you're not prepared for that and you don't have the proper level of PPE, then at that point, you're like, I'm going to get it,
Yeah.
And so we fully were covered. There wasn't a piece of my body that was uncovered taking care of those patients.
What do they know about dermal exposure? Like, theoretically, if you were to get vomit on your arm without an open wound, do you still have any risk of contracting it?
Yeah, I mean, the odds are, if there's not broken skin and you quickly wipe or decon, then you're going to probably be okay. But if you've got any breaking skin and that gets on you, it's a high likelihood there's a chance you're going to get it. Because I mean, you think about it,
yeah.
the patients who are the people who get exposed to the dead bodies that are handling them, they probably are trying to be careful, to be honest with you. But with that being said, they're still getting it. So you have to assume, okay, it doesn't take much of a break in the skin for that to get through.
Mm-hmm. So with the incubation period and the early stage asymptomatic period, how do you manage the people that are working? So say yourself working inside the ABCS, transporting an Ebola patient, you believe that you've done all the procedures correctly. Now you go back to the world. What does the post-transport process look like for the people exposed but not exposed to potential risk, to make sure that they don't become patient zero for the United States?
Yeah, that's a good question. And I think that really came up in 2014. Like, people were like, hey, they're going to bring Ebola to the country. And, I mean, we have very detailed processes to protect ourselves. Nothing's 100% foolproof, obviously, in medicine in general. And so to protect ourselves, we have a very good process of getting out of our PPE. We use the buddy system, make sure like we don't expose ourselves. And while getting out of our PPE, and we also try to, in quotes, decon any kind of exposure we've had to our PPE before we even try to get out of it. So we have a process of doing that. And, fortunately, we've had no significant exposures. With that being said, if you had one and you just didn't realize it, those are the ones you worry about, right? So what we do is we do self-monitoring. And when 2014 happened, I was in a constant state of self-monitoring.
Can't imagine.
I mean, I literally wasn't out of it for months. It just started the clock every time I did a trip or reset the clock. And so I would say, we did at least twice daily temperature checks. And we also did any symptom monitoring, and we had a very detailed process of what happened. So let's say I'm at home and I'm like, I don't feel very well. I feel kind of achy, and I've done Ebola trips. Well, I mean, I'm not going to, pretend like it's a common cold at that point, And so at that point, we are going to go and get tested and quarantined until we know exactly what it is. Mm-hmm. And so, I mean, that's an unfortunate part of doing the transports, is you may look at that possibility like, hey, I'm going to be stuck in quarantine for a while until I know 100% this is not Ebola. Mm-hmm. But it is what it is. I mean, we certainly don't want to be stupid and bring it to the American public and have an epidemic here. Mm-hmm. So it's very close monitoring, essentially. Now, let's say I'm in there and I had a body fluid exposure to my skin. Even if I had intact skin, at that point, I'm going to go in quarantine. Mm-hmm. I'm not going to be even self-monitoring at home. This is a detailed thing I'm going to be going through with the CDC. And where I live, I'd go to Emory, essentially, get tested, but be very closely monitored in a quarantine situation, because I'm not going to take a chance to give it to anybody else.
Yeah. So let's go back to that meeting. You said, right, from that first call, you go into the meeting. Now you're going to make the actual decision. Is this something that's feasible to accomplish? And then how do we accomplish it? So what are the kind of what are the kind of things that are being brought up in the pros and cons column as we go through that meeting?
Yeah. Well, that's exactly it. The first question was: is the containment system, is it capable of handling a hemorrhagic fever? And absolutely, we can. I mean, the airborne ones are the ones that are more transmissible, easily transmissible, really. And so we knew that we could transport any level of pathogen in that containment system. It had been tested, in a very detailed testing process even before we started using it. It's got HEPA filtration that is before and after as air comes into the system, air goes out. It's filtered before it goes out, and then it's exhausted outside. We also have negative pressure in there, and so and then the aircraft also, the flow of air normally goes from the back to the front in most aircraft. In our aircraft, it's actually reversed. So if we had a break in our containment system or a breach in our containment system, then the air is actually going to be filtered to the back of the aircraft and then also HEPA filtered. And so we have safety measures in place and redundancies there just to make sure that we're safe. So we knew the ABCS could do it. The next part is, can we do it safely, not just for us, but also not to bring it back to the United States, obviously. So that was a big question. I mean, the president at the time said, can we do this safely? Can we bring it back here, treat these people, and do it safely? And we felt that we could actually do it. And just because of our processes, we felt, that we could safely manage those patients and not put the public at risk.
Mm-hmm. In the book, they kind of detail this, and then we did it again, and then we did it again, and then we did it again. What was that like, making the granular changes of the process? Like what? Take me into your mind as in terms of like, all right, no, we can't do it this way. We got to do it this way. Oh, taking that glove off that way didn't work. We have to do this. And then also not only figuring that out, but then also documenting it in a way that's replicatable.
Yeah, that's a good question. I mean, so we tested doffing our PPE. That's the most important part, really, is when you're getting out of your PPE when you've had a patient exposure. And so we tested it, and I think, Kevin detailed that pretty well in his book when he talked about Vance and said, okay, you're dead. You're dead.
Yeah.
So we were testing it over and over again to say, okay, how are we going to do this? How are we going to work this protocol? And it was a step-by-step approach, but we also used the buddy system because, the big factor here is a number of things weighing on you physiologically and mentally that put you at risk for making a mistake. And so you've got the heat of Africa. You've got PPE that makes you also very hot. You've got the fatigue of flying there and then getting prepared to take care of the patient and then all the way back to the States. You've got the fear factor involved, like, hey, I don't want to die either. And you also have that fear factor of like, hey, let's do this right. Let's not mess this up, because there's always that risk to the American public too, although we felt it was very, very low. And that's why we felt it was worthwhile doing. And so all those factors play a part into making it dangerous. And so we have these protocols in place so that we can make sure that, like, hey, we're doing this safely. In flight as well as when we get back. Now, the other part of it is every trip we would debrief and we say, okay, what can we do better next time? What do we feel like should have been different? Our level of how the way we did our PPE did not change significantly in that time during the epidemic that we were dealing with. So the way we got out of our equipment didn't change a whole lot, but the little things here and there, like setting up the aircraft, how it was prepared for the patient loading and offloading, to setting up equipment and what we would have within the containment system. For example, one of the lessons we learned, the initial iterations of the ABCS had black shiny flooring. Well, guess what doesn't show up very easily and is easily seen on black shiny flooring in an aircraft, that the light isn't that great like it is in the hospital. Well, body fluids, right? So if you got blood or feces or vomitus on the floor and you're standing in it and you can't see it, you didn't realize you got exposed to it, then it's obviously that's putting yourself at risk. And so we said, hey, we came back and we said, all the rest of the tents that are made for these trips need to have white flooring so we can see everything that's on that system that we're potentially are exposing ourselves to. So those are some of the things that we actually were lessons learned. So I think every trip we had something that we discussed, hey, how could we have done that better? One of the issues that we had initially that changed now is, and did change with our PPE. Well, at that time we didn't have a respirator system that we could do easily and get out of safely and reuse to go back into the system. So we basically had Tyvek hoods on with a secondary hood, full face mask, N95 mask, like full covered face, but like that just infinitesimally made it more physically exhausting. Because if you're using a capper or a papper, and you've got airflow to keep you, number one, cool, but also like it's just easier to breathe and you're not breathing your own carbon dioxide, that fatigue level is way less than it was back in 2014. So from our safety standpoint, it's definitely better now than it was when we initially did it, because we're using a capper system that has its own self-contained, personal respirator, easy to get in and out of, but yeah, it gives us airflow. We also, the other thing too is we put huge. If you look at us on TV, we look like we're massive. Okay, that's actually because the airflow going into our PPE, but. So through COVID, for example, we look like the marshmallow man walking around because our PPE was 2 or 3 times bigger than we would normally wear. And so we looked huge in our PPE, but the reason is because we had to peel out of it to safely get out of it. And when it's form fitting, that doesn't make sense to do. And so we wanted an easy way to get out of it. And so to wear big PPE was the way to go.
So from figuring out this process, eventually, you make the call that we're going to do this, and you hop on a plane and fly to Africa, and you find yourself face to face with this, the scariest thing in the world at the time. What's that moment like?
It was surreal. I mean, I'm backing up a little bit to just kind of lead up to that. Yeah. So when we first started, and I think Kevin mentioned this in this book, when we were asked, can we do this? I volunteered to go. I said, I can do it, and so I wanted to be part of that mission. Obviously there's a little bit of a fear factor there too, but I felt like, hey, I want to do the right thing. I want to go get them out of there. And, you've got a good person over there trying to help people out. You've got a missionary over there, and they're an American, and I'm a patriot, to be honest with you. I'm a patriotic person. I believe in our country, and I will fight for our country. And so I'm one of those people that's like, yeah, let's do this. America, we're Americans. And so, and I think a lot of us felt that way. And some of my crews probably make fun of me because of my patriotic emails that I send out before we do momentous missions and historic missions. They're probably a little cheesy, but that's all right. I can deal with that. I can deal with the backlash of that. So I volunteered. And then when we were leaving, we kept it on the radar that we were doing it. But I saw news crews and I saw black SUVs, and I told Vance and I told Jonathan, the other flight nurse that was with me, I said, guys, look at the end of the runway. Excuse me. And there was some SUVs, and I saw cameras, and I said, they're going to know. And when we got to Africa and we arrived in Liberia, it was in the news. And so now when we got to Kent, our main goal at that point was complete focus. Let's take good care of them. Let's do this safely. We ran through it many times before we got to him. We walked through the process, not just a tabletop, but actually walked through the process. Okay, this is what everybody's goal is on this plane to do to get him in. And we all took turns being in the system with him. So we had equal exposure. And then, we were all equally at risk, if you will. And so all of us took turns being in the system with him. And so, I told Kent, I said, hey, listen, we're here to take you home. And if you need something, let us know. We're going to get you feeling better. We've got, we've got a ton of meds if we need to use them. We've got fluids, and just get some rest so we get you back to Emory. Mm-hmm. And so, he was a very stoic person. I mean, he was obviously very sick, but obviously didn't want to also let us know how sick he truly was at that point. I think he was just trying to be stoic, be strong. But I think there was that glimmer of hope, like, hey, I've got a chance to live now, because I think he truly knew he was probably going to die if he stayed there. Mm-hmm. And I think he would have.
Go ahead.
No, I was just going to say, I think he would have died if he had stayed there.
Okay. So that transitions me exactly into my next question, which is, what kind of facility was he in? Like, I don't have any, I've seen some videos of what kind of it looks like there, and I have no frame of reference really for what that facility looked like.
Are you talking about at Emory?
No. I can imagine what a beautiful advanced ER looks like. What does it look like in Africa?
Well, we didn't actually see where he was located at that time. He was actually in his close house. I don't know what it looked like, because at that point he had been separated. And then there were volunteers at Samaritan's Purse who were taking turns taking care of him. Yeah. A lot of the time they were just speaking to him through the window to try to distance themselves and not put themselves at risk. But if there was anything that needed to be done from a medical care standpoint, they would go into the house and take care of him. But at that point, his family was gone back to the States, which is, I'm very thankful for, to be honest with you. So they didn't get exposed to it too.
Yeah.
I mean, very remote, very limited resources. I mean, they're the true heroes, to be honest with you. I mean, just the ability. I mean, for example, he was never going to be on a ventilator or be on dialysis or be on advanced care that he would have gotten at Emory, that he could have, it just wouldn't be capable of dealing to that there. They had very limited resources to treat him there. And so, as opposed to advanced medicine at Emory.
And this is just a sidebar question. It's off topic, but I am interested. Yeah. So you're doing these rotations inside the ABCS. What are you doing when you're not in the ABCS? Are you engaged, or are you like playing Candy Crush on your phone?
We are still engaged. We would take turns such that if you just came out, you probably wouldn't just go right back in because you're exhausted. Honestly, we took multiple pairs of shirts because we were completely drenched in sweat by the time we came out. The way the ABCS is, and because of the way the containment system works with the negative airflow, it stays pretty warm in there, actually. And so we actually get the back of the plane really cold. So when you're in PPE, you're sweating and you're just drenched in sweat. You go from hot to like you're freezing. So we would come out and we just take our shirt and take it off and then put a new one on. And actually, after that first trip, I had sweat so much, and Vance and I actually had to decon the plane, so when we got back, we're completely exhausted. And then we were like, hey, you guys got to decon the plane.
Yeah.
And we're like, oh my gosh. Okay. And so I had sweat so much, I had to throw my belt and my shoes away because they were destroyed. Yeah. Destroyed. So we were resting.
What does this might be a too complicated question, but it might be, hopefully you can answer it. Like, what does the treatment complement look like it's essentially supportive care, right? There's nothing you're going to do to definitively solve it, but you are providing supportive care. What do these like actual rotations look like? Like, take me through, all right, it's time to go into the ABCS. What are you doing?
Primarily, you're just saying, you're checking on the patient. A lot of our monitoring any kind of intervention from a standpoint of medication wise, looking, running an EKG, manually, or not manually, but we've got auto periods of time where the blood pressure cuff's going off, obviously. But if we want to check another blood pressure sooner or later, all of our monitoring systems out of the ABCS. We have sleeves that go in, so you've got that negative pressure. They're taped off, so like there's just no way for anything to come through. But all of our lines, including our ventilator tubing, we've got extensions. So we've got long ventilator tubing. We've got long IV monitoring. IV tubing, and then all of our monitors have longer lines. All those lines are thrown away actually after use. So anything that goes in the tent, aside from the patient and us, does not come out of that tent. It's all deconned. It's collapsed. It's incinerated, actually, believe it or not. So it's actually, even though the decon technically kills everything in there, everything's incinerated. So when we're in there, we're basically saying, how are you doing now? Fortunately, Kent was not, aside from an IV establishment, and checking on him and so forth, inside the ABCS, we didn't have to do a lot of direct patient care. Everything, if he needed something for nausea, something for pain, something to help him rest, IV fluids, any electrolytes, anything like that, we could do outside the system. We just ran it through the pumps outside the system, and it ran through to the IVs through him. But we'd go in there and reassess him, do an exam on him, see how he's doing, sit with him for a while, ask him if he needs anything. And then on the other hand, there were patients that were very critically ill that we were transporting, that we were managing in the back of the ABCS. And so we were pretty much there the whole time. So Kent was supportive care. On the other hand, the other patients were much sicker. We're talking bicarb drips and stuff like that. And so those patients are a lot more high maintenance in quotes. But with Kent specifically, it was primarily just checking on him more than anything else, because we could do what we needed outside the tent. We had a comm system, so I'd say, hey, he needs some Zofran. And then the guys, could give him Zofran through the IV pump. And so we try to minimize, any risk to us too, doing procedures as much as we could.
So in talking specifically about Kent, you get him back, offload him. Obviously it's a circus. Like to say that the flight back was a circus is probably an understatement, right? Like there was problems of not even knowing if you're going to have a place to land, all these things. And at what point in that process do you realize that you've done it?
Well, once he got to Emory, I guess that's the final moment. To be honest with you, in my mind, I was already preparing for the next trip. So I knew I needed to get some rest so I could try to recover, because I was very sleep deprived at that point and physically exhausted just from the trip and also doing the decon. But the moment we got him off the aircraft into the ambulance for his ride to Emory, I think was probably like, okay, we got him here, but we still have more to come. And in my gut feeling, I knew, Nancy Ripple, we knew we were going to go back for, but I knew there would be others. Just the huge amount of outbreak. I said, there's going to be not only Americans, but at that point we knew, hey, there's a chance there's going to be non-American citizens that we may have to transport as well. And that worked for NGOs. And so the mission wasn't done, but I was really glad to get Kent there. It was a sense of that patriotic sense, like, hey, we're Americans, we can do this. But also to do the right thing for a person, you just realize like, hey, I gave him a chance to live, because I don't think he would have survived there, to be honest with you. And I think of most of the people that we brought back to the States, or to the European Union, they wouldn't have survived. The mortality rate was so high, and they just had such limited resources there. So
with that said, you say you just kind of got back on the horse more or less, and you knew you had another mission to do. Was there a moment I think you did 11 Ebola flights? Is that right?
Yeah. I did, all but 2 or 3. I'm trying to remember. it's been a while, 2 or 3 of the actual sick patients. Um, but so I did all but 2 or 3 of those.
Yeah. Was there ever a moment where you had like that letdown and like a big breath and saying, holy shit, what have we accomplished? Like when, if ever, did that happen?
I would say 2 moments. One is when we completed our last mission and safely, and we were okay. So none of our crews got sick. The other moment was when I realized like they're surviving. Kent's getting better. Nancy's getting better. Ian Crozier is getting better. The patients that we transported that died were really actually already behind the 8 ball. The problem with Ebola was the initial patients, some of them tested negative initially and then ultimately tested positive because they kept getting sicker. So they had some false negatives. And so when we got to those patients that ended up dying, they were already critically ill and behind the 8 ball. And, you know, one specifically that I brought back, it was a really, from a medical only, not emotional standpoint, you're looking at his vital signs, and you're like, he's okay. He was not okay. I took one look at him, and even before we got there, they said, yeah, he's doing okay. And Vance and I went, and we got there, and I looked at Vance. I said, he's dying. He's like actively dying right now. We need to do whatever we can to keep him alive. And so I was making hourly calls to the State Department, to the director of operational medicine for State Department, and saying, don't pay attention to the vital signs. I'm telling you, he needs dialysis as soon as he gets there. He's critically ill. I'm doing everything I can to keep him alive. And unfortunately, he did not survive even 24 hours. The other gentleman that died that we had taken to Germany as well and didn't, you know, survive. I think he survived a couple of days, but they were already behind the 8 ball. But I think in my mind, once I realized like, hey, these people are surviving, we're getting them to higher levels of care. They're making it, but also our crews are okay. We've had no major exposures. We've had nobody get sick. Those are the times when I finally let down and like my body just said, okay, you know, we've done this. We've done a good job with it. We've been safe, and everybody's okay. And I felt proud of it.
How do you go back to the normal ER? Like, how do you go back to tubby pains and stubbed toes and broken arms after that?
You know, it's funny you would ask that. I mean, I remember one day I walked in, you know, my hospital leadership was actually very supportive of what we were doing. And I walked in one day, and this was after we finally had to do a news release, and the news was just all over it. And we finally said, we've got to do a Q&A, and there's just no way we can get away from it. And so, because I was involved in the majority of the sick patient transports, you know, I was up there answering questions, especially the first one with Dr. Brantley. And so at that point, you know, it was in the news. I mean, everybody knew. And so I walked in the hospital, and I could see like a bunch of like prairie dogs sticking their heads up, you know, some of the staff looking at me. And I could tell, okay, you saw it. And that was like the news release was the night before. And the next day I'm coming in and I'm like walking to the hospital, take care of patients. And then the next thing I know, like, yeah, they know. And I said, I kind of stuck my head out of the care team and I said, yes, I was involved. And we're like, we knew it, you know. And so, I mean, I think everybody was proud, you know, about it, to be honest with you. I mean, I didn't do it for, I'm one of those people that's pretty quiet most of the time about what I do, to be honest with you. So I didn't do it for the news. I didn't do it for the notoriety, to be honest. I think just knowing that we made a difference was all that we needed, most of us medical, because, I mean, it was risky. I mean, we all knew it. At that time, I thought if I get it, there's a 70% chance I'm going to die. And early on. And so I knew the mortality rate was high at that point. We didn't know what Western medicine would change as far as mortality rate. We hoped it would be different. But I think it was that, hey, we did this. Obviously I'm that adrenaline rush person. I like to do stuff out of the box. Yeah, there's that excitement too. And like, hey, this was awesome. We just did something that's never been done. But I think to the core, most of the medical folks, like we had an emotional connection, that we did the right thing.
Mm-hmm. I hope you're okay with me prying a bit, but I have to wonder, what do you think your dad would think about this? Like from unfortunately he passed before you really got into this kind of more extreme, work. But what do you think he would think about what you've done?
Well, you might get me emotional. So, yeah, my dad's been gone for many years, but my dad and actually my mom's been gone for years now too. But my mom was alive through this whole thing, and she had told me that he would have been proud. My sister did the same thing. I remember calling my mom, and my family didn't know I did the initial trip, so I didn't want to scare them. But once they saw the news, and they saw the planes, then they're like, wait a minute. They knew who I worked for. They didn't know all the nitty gritty of all the types of missions we do. But I called my mom and I said, hey, Mom, I just want you to know I was on those trips and I'm okay and we're safe and we're doing it safe. We trust on our processes. And she was very proud. But I think, and she told me, she's like, your dad, he'd be very proud of you for what you did. So I get emotional when I think about it because my dad was an amazing physician, and I like to think that I followed in his footsteps, or at least have tried to. So yeah, I think he would have been very proud of what we did.
Yeah, undoubtedly, right? I mean, to take the skill set you have and take it to such extreme lengths to, ultimately I imagine him as, this patriot, a Vietnam veteran, all these things, like you being able to put your neck on the line for the country in the way that you did. I think it's pretty admirable and pretty amazing. But I'm going to let you go. I want to be respectful of your time, but I do want to touch a little bit on the current state of the world. Obviously, we're talking about what happened in 2014, but I kind of joked with Kevin. I was like, what a guerrilla marketing tactic to start an Ebola outbreak again to promote your book. But it's happening again. Unfortunately, there's sick people again in the world. Ebola is on the loose. We talked briefly before we started about, any potential involvement of Phoenix Air or anything that are we seeing round 2 happening here? To what extent you can, tell me what your feelings on the current outbreak are.
Well, yeah, I'm definitely concerned. I'm concerned for a number of reasons. One is the location. So in that part of the DRC, it's in a conflict zone, so not specifically safe. I mean, my hat's off to the NGOs that are involved in going to that location to provide care because there's a lot of conflict going on. So that's one issue. Ability to do contract tracing is difficult at best in that location as well. It's leaky borders between Uganda, Sudan. It's surrounded by other African countries, obviously, and I think people. Number one, especially in the beginning, didn't realize what they had. So they may have traveled to different locations, but there's probably people there that just want to go to areas that are less remote to maybe try to seek treatment. So you're exposing people along the way. And then there's no vaccine for it. After the initial Ebola crisis, there was a vaccine that developed. And I think subsequent outbreaks have probably been somewhat controlled by providing vaccinations over there that to try to help prevent the spread of it. So there's no vaccine for this variant. And then on top of that, I think the fact that treatment units are being burned down because people want to get to their loved ones' bodies to prepare them for burial. And this actually happened in Liberia and Sierra Leone. I think there's a lot of conspiracy from some of the people locally that think that it's brought in. It's not something that's, that originated from the area. Hey, you're not allowing us to see our family members. You can't do that, or we can't take over our family members that have died, and they're burning these units down. And so it's making it challenging for them to be taken care of. And on top of that, if you look at the graph, there's a nice graph actually that's out there. If you look at the worst epidemic that we've had, and the trajectory for the 2014 epidemic is like this. If you look at this one, it's like that. So much more vertical. And so from time of when we realize, hey, we've got an Ebola epidemic in comparison to 14, to the amount of cases is going vertical. So I think the governments are being smart about trying to like really provide resources so that we can try to control this. I think the next few weeks are going to be very telling, to be honest with you. I'm hoping that this is going to smolder out like the other outbreaks that we've seen since 2014. 2014 was just terrible because it was right next to a big city, and Monrovia there, and also you get up into Sierra Leone. So I think we need to be extremely concerned from a local standpoint. Now, the rest of the states, with closing the borders, good travel monitoring, the hospitals paying close attention to travel, that's going to be the smarter way for us to prevent us from getting in the U.S. But there's always there's a quote in Jurassic Park: "Life finds a way," right? So life finds a way. So there's always a chance. Like if you look in Brazil, they had 2 patients down there. They were concerned had Ebola. One was from the DRC. The other was from Uganda. That one ended up having meningitis. The other one ended up having malaria, but they're still being monitored and tested for Ebola because they had similar symptoms to Ebola. And so it puts a unique challenge for all of us in the United States, because the world is a small place now because of air travel. Atlanta Hartsfield, busiest airport in the world, direct flights in from Africa. So they're very, very closely paying attention to travel and the travel ban. So I think if we're smart about it, we'll be okay. But I'm very cautious to say we're okay right now in Africa. And I think we really need to be on top of what's happening over there, because it's a high risk of this becoming a worsening epidemic.
Well, what a cheery note to end on, right?
Yeah, cheery.
Yeah. But truly, thank you for more even than, maybe not more even, but thank you for doing what you do. Someone has to do it. And it's brave people like you that, put on the suit and get the training and do all the work that is desperately needed. And beyond that, thank you for talking to me. We joked before that you are, a person that is not a public facing person generally. And so I appreciate you taking the time to talk to me, tell your story, because the story is extremely compelling. The book is super great, but ultimately the book is your life. So thanks for having a life worth telling a story about, so that we can learn from it. So
thanks so much.
Thank you for coming on the show to talk. It's been a real pleasure.
Thank you very much. I appreciate it. It's been my